Wes here. And I think also Diamono, him, I have seen his emails, but I've not had the opportunity to interact. So this is really a fantastic opportunity. And thanks, Afreenish, for
We lost you.
Kwame, we cannot hear you. No, the voice is not clear.
Yes, so the problem is from here. So I'm trying to fix it. I'll get back to you. Maybe you may take over.
Now it's a little better. Can you repeat it again? Sorry. So you're mute actually, Kwame.
Can you hear me now?
Yeah, we can hear you now. Yeah, thank you.
The chair of the team of
Kwame, it is a problem with your, we cannot hear you very well. It keeps on disconnecting or somehow the voice is not clear.
discussion is
现在还要开会，那怎么办？现在还加进。
I request the other participants to kindly mute their mics. I can see some of the participants. Please mute their mics. And Professor Kwame, we are not able to listen to you very clearly. So,
hello. Hello.
Yeah, we can hear you.
Okay. Now, hello. So, Catherine, I think you should take over since you are going to do the panel discussion.
Sure. So, thank you, Professor Kwame. I'm really sorry. There was some problem with the connection. We were not able to hear you very clearly. But we are going to start our today's webinar with a warm welcome to every participant. And today we are holding this webinar under the Global Health Security Agenda AMR Action Package. And the AMR Action Package is led by a tri-chair right now by US, by Ghana and Pakistan. And I can see the representative from US, Angela will be here, and Christian will be here, and Kwame is representing Ghana, and I am representing from Pakistan. So the GHSA Global Health Security Agenda, AMR Action Package particularly works to collaborate and to build the collaborations and coordinations between different countries across the globe. And the main agenda is that we have to promote the mitigation efforts towards the antimicrobial resistance. So under this platform, we are doing number of collaborative efforts and number of discussions with different partners. And this webinar is one of the continuity of one of the actions that we are going to hold today. First, related to the topic, I have some few slides to present to you just to set the background for our panelists for the next discussion. So I'm going to present some of the slides over here, and then we can move towards the formal discussion. So to begin with, how do we define this equitable access to the antimicrobials? And we all understand by the terminology. The idea is that we have to ensure that all the individuals regardless of their socioeconomic status or the geographic location, they have timely and affordable access to the essential antibiotics and diagnostic tools. So this is the main background, and this is a really concern for all of us these days, and very important factor for controlling the AMR. And very recently in the United Nations General Assembly, there's an AMR declaration. And there are some of the few points that I really wanted to present over here, just to set the background that where are we heading towards. So the UNGA declaration, that they have a clear understanding towards the growing concern of the AMR, and they have highlighted number of the factors that should be considered while controlling the AMR. So the equitable access to the antimicrobials, they consider it as a very big challenge, particularly for the developing countries. They have highlighted that the supply demand on manufacturing facilities, it is concentrated in few countries, and there is a lack of the national and the regional policies related to the capacity building. The third point that the UNGA, they consider it really important is the high price and out-of-pocket expenditures. That is a big hurdle towards the mitigation efforts of the AMR. So beginning with this introduction, what they have committed in 2024 in the United Nations General Assembly, some of the key areas related to the topic today is that they always highlight that there should be an accelerated efforts to achieve the universal health coverage. And then there's a commitment that all the stakeholders should be working to ensure the equitable and timely access to the antimicrobials, not limited to antimicrobials, but to vaccines and diagnostics, particularly in developing countries. And they have to bring this equitable access in line with the WHO model list of the essential medicines and the global essential veterinary medicine list. The declaration number 44 that particularly highlights to build the coordination efforts by the quadripartite and other stakeholders to ensure these equitable access to the antimicrobials and diagnostics. And the last important point was very interesting. They were trying to highlight the role of the policy change and what should be done towards the establishing the implementing new sustainable procurement models, such as the pool procurement, tiered pricing, or some support measures for the supply chains. So this is some of the commitments that are being done, and the member countries and all the signatory countries, they are really working, and along with our organization and different organizations, they are closely working to achieve some of the commitments that are mentioned over here. And here I was just going through the number of the articles and the documents that are being published over the time. And we can see that different organizations, including ASM. I request the other participants to please mute their mics. So we can see that ASM, CarbX, ICARS, GARD-P, and other organizations, AMR, Industry Alliance, AMR Narrative, there are different groups who keeps on struggling and trying to define the efforts that should be done for the equitable access of the diagnostics and the antimicrobials. ASM has generated a number of the policy recommendation and documents to combat the AMR. Similarly, you can see on the left side, the document by the React Africa. There is some documents published by GARD-P. ICARS has been really active in number of the activities and during the development process of these declaration and commitments. And they keep on doing the webinars and the activities. So many of the times what we have seen that there are the overlapping areas and that are being discussed to ensure the equitable access to the effective antibiotics. And so I just need to stop over here, and we will look forward to from our panelists from different organizations so that they can share their experiences and provide us some answers to the questions that we pose to them. So I just stop over here, and we can move towards our panel discussion for today. So to begin with, we have like 4 esteemed panelists with us right now. First of all, I would like to introduce Ghada Zoubiane. Ghada Zoubiane is the head of the global health for infections at LifeArc, and she has a huge experience of 20 years in both the public and the private sectors. And she has been executing the research strategies at the national and the international levels. She has been working at the ICARS as the head of partnerships, and they have developed a number of missions and strategies. And she remained keep on working on different organizations at Wellcome, at UK Medical Research Council, and her work has been phenomenal in the field of the AMR. Thank you, Ghada, for joining us today. Next, we have Wes Kim. Wes Kim is the director of the ASM Global Public Health Programs, and he has been phenomenal in building the microbiology laboratory capacities across the globe, particularly in the low resource settings. And Kim has been working as a senior program officer at the Pew Charitable Trust and developing policies and advocacies. He has a huge experience of management consultant with different organizations. Thank you, Wes, for joining us today. And then we have Professor Tim Walsh. He has more than 30 years of experience and published number of articles in reputed journals like Nature and Lancet. And we have seen his work in most of the notorious antibiotic resistant genes, NDM1 and MCR1. He has established the Oxford Institute of Antimicrobial Research. His work is not limited to the high-income countries, but he has done a lot in the low-income countries like in Africa, South Africa, and in Pakistan as well. And thank you, Tim, for joining us. And then we have Damiano. Damiano is working as a chief scientific officer at the CARBX, and he has been doing a number of partnership and global activities in the field of AMR. And through his efforts, we have seen number of establishment towards the policy and evidence-based in the field of the AMR. Thank you, Damiano, for joining us for today. And with this, I go towards the questions particularly, and don't want to waste the time. So to begin with, I think we can begin with Wes. Wes, from your side, you have a huge experience in working across different parts of the world. And so what are the biggest barriers to equitable access to diagnostics and antimicrobials in LMICs for controlling AMR? How do you see the biggest barriers?
Thank you, Afreenish. Appreciate the opportunity to join you and this distinguished panel of experts to discuss this important topic on AMR. I think your slide talked about the cost of diagnostics and antimicrobials as a barrier, and I would wholeheartedly confirm and echo those sentiments. But I think we need to, simply saying reducing the cost of these goods is more complex than what's needed. If you're on the ground and looking at holistically some of the systems. And regarding the barriers, certainly cost of diagnostics and antimicrobials continue to be a substantial hurdle. But let's look at some of the complications of these cost impediments. Before I begin, just setting the context, during the COVID pandemic, I think one of the lessons we learned was the importance of microbiology laboratory systems, not only for surveilling for new strains of COVID, but also for diagnosing patients. And unfortunately, in many parts of low-income countries and low-resource settings, microbiology laboratory systems and infrastructures are inadequate. Looking at the system holistically, for example, the sample transport network is a challenge that needs to be addressed, particularly for populations in remote areas. This includes collecting and transporting patient samples in a quality-assured manner, such as a temperature-controlled environment, and so that it can get transferred to a lab that can eventually run the test, have the test analyzed, the results analyzed, interpreted, and then those results reported back to the patients. I think in many of the higher income countries, we take it for granted that we have these systems available to us. Sometimes we can just mail our samples into a postal service or have Amazon pick it up, and then in a few days we get our results. But that's not the reality in many parts of the world, particularly those countries that have high burdens of AMR. And so if we think about, okay, well, how do we design and operate a laboratory network that the first thing that comes to mind is, well, it requires substantial amount of budgets. And a lot of these low resource settings don't have these budgets. So just to reiterate that it's not simply just reducing the cost of diagnostics. It's looking at the system. But let's look at we can zoom in and look at the diagnostic machines, particularly those used for identification of pathogens and even automated susceptibility testing. These are expensive, and so too are the reagents to operate the machines. Furthermore, these types of machines require reliable sources of utilities, such as electricity, clean water, and it's not necessarily a given in many parts of the low resource settings, and that adds complexity and, of course, additional costs to operate. As does maintenance and repair. I've seen these types of equipment sitting idle in labs for over 6 to 9 months, if not longer, due to some of these issues. And even when these expensive machines are donated to the labs, all too often, they just end up sitting idle because laboratories can't afford to implement them into day-to-day workflows. So again, it's yes, the machines are expensive, and I should contextualize my statements that for this particular, I'm not just talking about some point of care testing. I'm talking about a lot of these large equipments for AMR surveillance, identification, and susceptibility testing. And now just switching gears a little bit for drugs. Also, yes, cost is a barrier. And there's both newly approved registered drugs and there's generics. So for novel, recently approved antibiotics, it's a complicated market issue. Most antibiotics developers are not able to market to low-income countries or even some high-income countries because the cost to do so is prohibitive. So relative to the revenues that they would generate, they would actually lose money to market their newly approved drugs. And that's why we see over the past decade, a lot of the biotech startups who had FDA approvals end up going bankrupt. We see large pharma companies historically who had developed these very important life-saving antibiotics. They shutter their antibiotics R&D because it's not profitable, and so they shift their gears to, for example, oncology, where you can make a pretty good living off of developing oncology drugs. So there is, yes, we can reduce the cost, but there's a whole, if we look at it holistically, we also need to look at it from a market perspective. And then just to wrap up, just generics, right? Even generics, there's a cost element, but there's also still a supply issue as well. And so, we'll get into, I think, later in the conversation of potential ways to address these challenges. But a lot of, and I think your slide also hit it on the nail, that in-country or regional manufacturing is insufficient and needs to be propped up and expanded. So I'll pause there, Afreenish, and thanks again for the question.
Thank you, Wes. And yes, I totally agree with you. The number of the points that you have mentioned, talking from the sample transport, the challenges with the sample transport, the cost of the equipment, and then the cost of the maintenance and the reagents. I totally agree. There are a number of factors that remain a major challenge in many of the LMICs. And this makes me to talk to Tim. Tim, you have a huge experience in the field of the diagnostics and innovations and novel methodologies. And how do you see that? We can see that there are novel things that are being innovated in diagnostics and antimicrobials. How can these innovations be made accessible to the undeserved populations to combat the AMR?
Thank you for the question. Also, thank you for the invitation to be part of this panel, part of this meeting. I think, first of all, diagnostics are really important in terms of shaping antimicrobial stewardship programs. But however, I think in terms of innovation, I don't think we should conflate or confuse the two. I'll come back onto antibiotics in a minute, but in terms of diagnostics, I think just going to what actually Wes was mentioning there is to understand is actually what the cost deferment systems are in each of the countries. And also, Afreenish, you are, in Pakistan, but Islamabad and Karachi is very, very different to, say, in Peshawar, for example, or in Lahore in terms of a population and what they can afford. So understanding the local economic needs and the cost deferment systems in these countries and also health insurance, I think is really important. Trying to understand exactly what the patient ends up paying for is super important. So, at the moment, diagnostics are really high, as Wes has said, but actually antibiotics are reasonably cheap. A daily dose of gentamicin plus ampicillin is what, $3.5, $4. That's kind of within range of most populations, around the country. But the diagnostics are very, very expensive, which is kind of why diagnostics are not done and they cannot shape or refine good antimicrobial stewardship programs. So understanding the health systems. And so I think we need to, in terms of innovation, if you like, what we could call reverse engineering, find out what the local needs are, finding what the cost structures are, and then work from there. Don't bring a piece of fancy kit in that's going to cost $30, $40 a hit, because nobody's going to use it. As Wes says, it would just land up in a corner of the lab and it would just be a white elephant that nobody will service. Also, a lot of the countries, that we're speaking about in terms of underserved populations have DAMA, discharge against medical advice. Why is that? That's because the patients and the parents of the patients cannot afford it, the therapy. And I think we just need to start listening. We need to be in listening mode to these underserved populations as best as we can. I think in terms of innovation on antibiotics, it's kind of really interesting because we often use the plight of AMR in LMICs as a means to go and develop wandamycin. But a lot of these countries don't actually have decent watch antibiotics or reserve antibiotics. So, for example, in Pakistan, again, another example, they've moved from gentamicin and ampicillin into amikacin or piptazone and ceftazidime for the treatment of neonatal sepsis, which is, absolutely fine. But then having access, for example, to meropenem, which would be the next step up, is not always available. So it's not a case of, I think, innovation in terms of good antibiotics. I think what we need to do, which we'll talk about later, is having or allowing access to affordable, appropriate antibiotics to manage patient populations.
Very interesting. Thank you, Tim, for highlighting the system need. I totally agree with you. I cannot go beyond it. What is the system need? Many of the times, very costly antibiotics, they are not affordable by the low-income countries, and that should be very much considered while developing the antibiotics and then supply chain system for the antimicrobial, even for the diagnostics. Thank you so much. And next, I would like to talk to Ghada. Ghada, I know you have a huge experience of working in different countries, and first we would like to hear your work at LifeArc, and definitely, and next we would like to hear from you that how do you see that, what strategies should be done to improve the access to the diagnostics, and second, to combine with it, what role can international or collaborations and partnerships can play in promoting this equity?
بعدين هذه البزنس
Thank you
قاعد تصير
very
بوابة
much,
لإيقافات لا متناهية.
Afreenish.
Kashyap, can you please
بعد
mute the
يغطي
mic
هو.
of Mr. Ans? Yes, sorry. Thank you so much. Yes, Ghada, please, sorry.
Thank you very much, Afreenish, and it's great to be following up from Tim, really echoing everything he said. But it's worth just to say a couple of minutes on LifeArc, because it is a newcomer to the global health field, and I have joined it recently. And LifeArc provide funding, but as well expertise and even lab capacity for developing innovation and accelerating innovation translation for near patient impact. And we work on many areas of global health and national challenges, but my area that I work on is global health infection. And over the next 3 to 5 years, my focus will be very much on focusing our effort on preventing and controlling resistant infection in highly impacted population. And when we work globally at LifeArc, we're not only working in whatever is considered low, middle, or less resource setting, but really where the burden is, which could be as much in the UK as it is in other parts of the world, depending on the need and the gap. Everything that we will be doing and we are currently doing will need really to work into making sure that the innovation is informed by the local need, that it has local ownership and leadership, and that access, stewardship, and affordability is considered. Now, this is, of course, very relative depending on the setting you are in. But when it comes to, for example, diagnostic and access to diagnostic, it's very important that we have different ways of working, that we can de-risk some of the innovation development and reduce the development costs. That doesn't, of course, cancel the more downstream challenges of really bringing an innovation into the market, and very much so what Wes and Tim was talking about, incorporating those innovation into the health system. We have a big department in diagnostic and devices development, and we are talking a lot to them across different disease area about the challenges of adoption and why would anyone be able to be using this diagnostic tool if actually it is totally out of pocket and many cannot really cover it. So how can we bring innovation to reduce the cost of the development, so that at A, you de-risking it, B, you're bringing partners on the ground, again, as Tim said early on in the discussion. If you want to look at a certain challenge in one area, what do you really need the most sophisticated, fancy piece of equipment? Or would it be a diagnostic that will tell you, or a test that will tell you, well, go seek doctor's approval? In one of the projects we're doing in India, the aim is actually to encourage hard-to-reach women in rural setting to say, with this strip that is a very simple strip, you should go talk to your doctor. This is what the tests need. It doesn't give you the profile of what you have. It doesn't give you the profile of the resistance. But for that purpose, the ambition really is for the healthcare worker, the ASHA in India, to engage with those women who, for if they have UTI infection, they considered a bit of a taboo to actually even talk about it. So I think depending on the challenge, the purpose, the gap that we're trying to address, the innovation has to follow, rather than having an innovation that we're trying to fit it into a system that actually doesn't work. Another piece of work that we are very keen on doing is bringing innovative tools such as antibodies. Everybody heard of antibodies in during the pandemic, right? It's very ambitious, but it's very expensive. It has a lot of challenges, and we're working with entities like the Gates Foundation to see how we can have a low type of cost for monoclonal antibody, for example, development, to make it cheap enough that it actually a wider range of population can benefit from it. So bringing innovation closer to the need, closer to the society, is where we should be going moving forward. And for that to happen, collaboration and partnership, and this is why I think as a part of my refined strategy is LifeArc does not need to lead. It needs to be a catalyst for change. Just, can we do things in a different way? Can we bring the techie person closer to the policy person, closer to the regulatory, and very importantly, at the heart of it, the people who actually we are tailoring these innovation to. So that's my advocacy effort within LifeArc and beyond, is to have a different way of working closely and acknowledge and respect the effort by other organizations. Most of them you have invited here on the panel. These are organizations that have a great portfolio of activity that we can all benefit from. Thank you, Afreenish.
Thank you, Ghada, and very interesting. And I totally agree with you on the same thing, that the need should be like, or the it should be tailored, it should be customized according to the system, according to the country's capacities. And we see a great work from your side and from your organization since many years. Thank you for that. Next, we move towards Damiano. Damiano is representing Carbex and doing a number of activities towards a sustainable financing, human rights, and different other activities. So Damiano, from your side, we would like to hear what work Carbex has been doing, particularly related to today's topic, like how to ensure the equitable access of diagnostics and antimicrobials. I know a number of activities are being conducted. And again, the same questions from your side. How do you think that the global partnership and collaborations, they can ensure the fair access to the antimicrobials?
Thank you. And thank you, Afreenish, for inviting us to this webinar. I think it's, to start with, I think it's great to see the work of the action package on AMR of the Global Health Security Agenda to get restarted. And so we very much, I think, welcome the new enthusiasm behind, I think, this webinar and future activities. I'm Daniele De Felice. I'm the Chief of External Affairs at CARBEX. As a quick summary, CARBEX is a global public-private partnerships which receive funding from multiple governments and private foundations. I'm speaking here not on behalf of the governments and foundations that support CARBEX, but on behalf of the CARBEX team. And I find it important to mention that CARBEX supports the development of new antibiotics and therapeutics, but not only that, we also support the development of vaccines and diagnostics, which is sometimes less well known within the community. So we have funding calls and we have a portfolio of products across three pillars. Therapeutics, preventatives, and diagnostics. CARBEX is a global partnership organization, and I can think of, based on our experience, multiple ways in which global collaborations and global initiatives support the development of novelty products and the accessibility, affordability of these products as well. The first one is fundamentally fundraising. I mean, we raise funding for product developers which develop innovative products to prevent, diagnose, and treat drug-resistant infections. In many cases, we know that the product developers are small companies that would have the ability to speak with governments and private foundations on their own to raise funding for the products. And what CARBEX does is fundamentally bring them together and fundraise for the R&D ecosystem as a whole. We build on the capacity of the team also to involve ministries outside of ministries of health and ministries of research. We have been speaking with ministries of finance, for example, to communicate the economic case for innovative diagnostics, vaccines, and therapeutics. And this is why, for example, we've been working quite closely with the G7 governments and including the presidency of Canada of this year, Canada, which is one of the funders of CARBEX. This is important because the sources of funding for AMR product developers can be varied within governments. Sometimes you have funding from the Ministries of Research, sometimes from the Ministry of Health. In other cases, it's the Ministry of Foreign Affairs. And it is important to collate these funding lines because some of them are very much tailored to low and middle income countries. Some of these funding lines are ODA related, and so they can be used only for products which have value for low and middle income countries. Other funding lines are mainly for scientific activities in high income countries. And combining the two is quite important to reach a critical mass of sustainable financing. A second role for global collaborations like CARBEX is to bring the private sector as part of the conversation, part of the solution. So we are a non-profit organization. Our board is organized across governments and private foundations, but we mainly support and finance private organizations and universities. And so it's very much our role bringing the ingenuity of the private sector into game, to develop new products. The way in which we prioritize access and products for low and middle income countries is fundamentally through the selection of the products that we support. The portfolio, when we build the portfolio, it's based on an R&D strategy, which will be reviewed again next year. So happy for you to reach out if you're interested in participating in the process. We speak with global key opinion leaders, scientists, clinicians, funders, policymakers to understand what the priorities are in terms of potential products across the world. And we translate their input into funding themes. And we have call for proposals which are open to product developers anywhere in the world. Supporting product developers outside of traditional R&D ecosystem is also very important. We've been supporting, for example, on the diagnostic side, several product developers in India. And this is something that we're now exploring even more in terms of how can we support a stronger R&D ecosystems in key areas in low and middle income countries, recognizing that the development of products for low and middle income countries happens best when it comes also from low and middle income countries themselves. And finally, I find it important to mention that we have specific contractual obligations in all our grant agreements, which require product developers which receive support from CARB-X to develop stewardship and access plans during the R&D process itself. So we ask them fundamentally to think about access in low and middle income countries before market approval, even before market approval in high income countries. We do recognize that this is a necessary step because we want product developers to think about access and stewardship, but it's not a sufficient one. We do recognize the importance of sustainable financing, and this is why I think the work of LifeArc with partners in low and middle income countries, the work of ICARS with governments in low and middle income countries is also fundamental. And this is why I think the three organizations here and a few others are very complementary and synergistic in addressing a quite complex problem, which is to bring like new and much needed products to low middle income countries.
Very interesting. Thank you, Damiano. And I totally agree. The point of the policy and engaging the government and engaging the different stakeholders, and then assessing the need and generating the funds and prioritizing what is required. I really look forward to the new R&D document that you guys are working on, and definitely that can be a big help for all of us to understand what is the need actually and how can we prioritize. So this brings me again to Tim. Tim, from your side, I would like to understand that what do you suggest regarding the availability and the affordability of the essential antimicrobials, particularly in LMICs? We understand the challenge over there, but what best strategy that you can suggest to ensure that the essential antimicrobials, they are available and they are affordable in LMICs? And to connect with that, the second part will be how can we promote the antimicrobial stewardship, particularly in LMICs?
Okay, thank you. Very quickly, so I will deal with antimicrobial stewardship systems in a moment. But I think in terms of affordability and access, I think, again, we have to start listening to local needs. I'll give you two very quick examples. First of all is that when we worked in Murtala Muhammad State Hospital in Kano, they weren't able to access amikacin, and they actually needed amikacin because the mortality of neonates was very, very high. And so we helped to provide some data so that they can then go, and the evidence is critical in order to make the case for the import for a license for amikacin into the state of Kano. That was really important. And then neonatal sepsis dropped, well, actually mortality dropped from something like 34% down to about 15% by actually having the right drug into the right group of patients, in this case, early onset to sepsis and late onset to sepsis. The other example I would give you would in DESI, where we worked in a neonatal unit, and the only drug available in the hospital, in the pharmacy in the hospital, was ceftriaxone, which was actually inappropriate. But then you had this rather strange situation going on where mother one, or I should say mother A on day one, would go to the local pharmacy and actually buy meropenem and then bring meropenem back into the neonatal ward and share that around all the babies. And then on day two, it would be mother B, and then on day three, mother C, and so on and so forth. And so when you look at examples like that, it's a case of this is not really particularly difficult. The antibiotics are actually there available in the local pharmacies. It's a case of whether those drugs are made available now in the hospital environment, the cost of those antibiotics. And again, I'll come back to the deferment process and who can afford what. This is really, really important. In the case of those mothers in DESI, they were sharing one vial amongst 6 or 8 babies over one day. So the cost is shared, which is great. And then we can sort of talk about supply chain.
It's all going to be done before they come. So,
we can talk about supply chain and then pharmacy stockouts, which is really, really important. On top of all of that, it's slightly more complicated because you have counterfeit drugs in a lot of these countries. And what we don't actually have a window on is also the internet sales of antibiotics, which nobody actually has a window on that. And we think it's probably massive. Go back to the second point about antimicrobial stewardship programs. ICARS has a great many antimicrobial stewardship programs in Central Asia, in Southeast Asia, and particularly across Africa. And it's simply a case of getting the right drug to the right, patient for the right duration, the right dose, etc., etc. But it's also, I think, understanding, what is affordable and what can be implemented in these countries. The UNGA targets was the reduction of mortality by 10%, but also a reduction in antibiotics by 30%. And that is slightly counterintuitive. And the only way we can achieve that is by having good diagnostics that will actually inform the appropriate use of antimicrobials. So it's about getting the right drug into the right patient, at the right time. And then diagnostics are fundamental to that. I think we can overall reduce antimicrobial use, but we have to do it responsibly. And the one thing we cannot do is to incur an increase in mortality. So understanding exactly what data is being collected from these countries and how we can use that to inform AMS programs is absolutely vital. And that's one of the things that ICARS is doing at the moment, is helping to collect that data to make sure that our AMS programs will achieve what we hope they will achieve.
Thank you, Tim. And I totally agree. The examples that you have given, this is the thing that is required, the advocacy, not only at the pharmacy level, but the clinician level, and then at the lab level, that all needs to be done, awareness and advocacy. And the second point related to the AMS interventions, exactly, the targets that are identified by UNGA, that can only be achieved by the strategies that you have just proposed. The surveillance data helps a lot in this thing. And we look forward to the countries to generate some of the quality data as well. And this brings me to Wes. Wes, we would like to hear from your side. You have been doing a number of activities towards this generation of the policy documents. And what do you suggest? What should be done at the policy level to ensure the equitable access of the diagnostics and the antimicrobials, and particularly in context of LMICs?
Thanks, Afreenish. So just starting at a very high level, and I think we've 2025 has been a very interesting year, if not chaotic. And so what we've seen this year today is billions of donor funding disappearing in a matter of months, right? And so with that said, I think any initiatives, policy has to have sustainability. And I know that's like a very popular word these days, but it is when it comes down to showing impact and being good stewards of donor funding and maximizing every dollar spent. Sustainability has to be a core element, and there's multiple ways to achieve sustainability. As I mentioned at the onset, I think in the longer term, having countries be able to manufacture their own drugs, antibiotics, antimicrobials, diagnostics, that will go a long way in terms of country ownership, but also, as we saw with the pandemic, when there was a scarcity of vaccines and diagnostics, and guess who ended up with the majority of the global supply, right? So as more and more countries, and we can support countries, particularly LMICs in those regions, to be self-sufficient in development and manufacturing. So tech transfers certainly are great vectors to look into. Now, going a little bit more specific into diagnostics, and this was alluded to previously, I think, by one my colleagues, panelists here. Even if it's not just about saying, okay, we're going to support a country, but looking at the country systems. Usually the capital of a country has a lot of resources, and usually a lot of the national action plans have been targeted to supporting at the national level. And the goal was for, once you capacitate, for example, a national reference lab, then that national reference lab should be able to train state labs, local labs, and share that knowledge. So I think more of that needs to be done, because a lot of the remote populations don't have readily accessible access to a lot of the laboratory capabilities that exist at the National Reference Lab or well-funded state labs. So I think that's one of the areas that needs to be continued to be emphasized. And then I think Professor Kwame had mentioned this in his comments. It's about building laboratory capacity, and it goes to the laboratory professionals and the scientists. I've seen a lot of laboratories where the technicians are trained to use the machines that were donated or purchased without understanding the fundamentals of microbiology testing. So what happens when electricity fails? The reagents are back ordered. The testing, patient sample testing stops because the machines are not working. Well, a way to mitigate that is to train technicians to how to do just the fundamental, or the quote unquote the old ways of doing susceptibility testing, right? It's like disk diffusion. But a lot of these technicians are not trained to do disk diffusion. So when these expensive machines come to a grinding halt, then the laboratory stops operation. So what I'm advocating for is, yes, we should try to automate and simplify and maybe even reduce costs that way. But we need to train laboratory microbiologists to be able to test through traditional methodologies, I guess is what I'm trying to say. And then from the drug side, we talked about market issues, and I think more full incentives for novel antibiotics that would help these companies to invest more into R&D, and then also provide a revenue stream so that they can market into other countries. And I know the UK and I think Italy have piloted some forms of pull incentives, and hopefully that momentum continues to build. US, still holding my breath to see if anything happens in the US, but I know there's a lot of advocacy going on in terms of pull incentive policies. So again, just to reiterate, I think whatever solutions and policies we develop, sustainability has to be at the forefront. So thank you.
Thank you so much, Wes, for a very detailed explanation of the different elements that needs to be considered for the policy development. And I can see Professor Kwame, he has raised his hand to share some thoughts, and then we can go back to the panelists if you want to share some thoughts.
Thank you very much, Afreenish. Very, very insightful discussions. Very important points, being raised, which is really key and relevant, for the various actions in low middle income countries of antimicrobial resistance. There are some questions. I mean, one of the things that actually hit me was, and I think we have seen it before our eyes, where big pharma is actually folding up in low middle income countries and getting into R&D in other profitable areas. And that, I think, brings to the fore the role of CADBX, which is actually working to bring some innovative medicines, particularly to deal with, AMR. There's a question in the chat box for them. The question is that how receptive are the ministries of health in developing countries to R&D approaches, and what strategies can help ensure sustainability of R&D outcomes? And again, also the issue of sustainability. I think that should also be part of the response to this. And to Wes, Wes has been, American Society of Microbiology has also been supporting other capacity building initiative, using a tele-mentoring, strategy online educational programs, which is really making an impact. So I thought he could also highlight his experience on Teach AMS is doing in terms of strengthening capacity in low middle income countries for antimicrobial stewardship. Over.
Thank you, Kwame. And this brings me to Damiano. Damiano, I can see you have responded one of the query that have been posted for you in the chat box. So just coming back towards that, our main first thing, we have seen the UNGA declaration, the targets they are being identified over there. And what are your thoughts on this thing, that what role international commitments can play in promoting this diagnostic and antimicrobial equity? Damiano, your mic is mute actually.
Sorry, I'm sorry. So what I think what we've seen in our experience in the past few years is that having multiple governments come together to discuss the problem of antimicrobial resistance has highlighted how governments across different regions and across different income levels also face similar challenges in reality. I mean, there are multiple high-income countries which may be too small, too peripheral to normal markets, which they realize that they are treated as a low middle income country in terms of access to certain types of products, both in terms of therapeutics, but also other types of products. And so what was, I think, revealing in the conversation towards the political declaration, but also other settings, and I'm sure this will be a topic for your conversations within the action package as well, is how to build a solution which speaks like to multiple countries and countries across different regions, across different income levels. Coordination will be crucial, and this is why having international objectives, targets, and discussions is important. We cannot rely on vertical programs like 20 years ago to address the problem of AMR. And so in a multilateral world without a vertical program, what we need is multiple governments to come together within the government sector and the public sector, but also with the private sector to try to address this problem. And this is why even within the Global Health Security Agenda, we know that you have an R&D task force, an R&D committee, which is somehow parallel to the work that you do within the action packages. And we would encourage you also to consider how the work of the AMR Action Package can benefit from the work that you're doing on the R&D committee and put, I think, the two work stream together. There will be a ministerial conference on antimicrobial resistance next year in Nigeria. I think the community very much look forward to this conference as a midpoint after the political declaration. It will be the most important gathering after what we saw last year in New York. And so I think we all look forward to see how the Nigerian government will prioritize certain topics over others for the conference. And we expect also to take potentially, I think, a regional approach, obviously with Sub-Saharan Africa being like one of the regions which is most affected by antimicrobial resistance.
Thank you so much. And I guess gradually we are heading towards the closing. We have last few minutes left. I can see one question by Patrick. And I think any of the panelists, they can answer this question. How can one health approach be received by developing countries to address AMR? And in developing, how sustainable is one health approach to address AMR? So floor is all open. Any of one of you can answer this or share your thoughts. Tim,
I think there is also a
yes, Wes, please, yeah.
There's also a question on local production. Any reflection on local production? Yeah.
Yes, Wes, please.
Yeah, I can start the One Health. So we are very fortunate to be the country grantee for Tanzania, and through the Fleming Fund, which emphasizes not just the human component, but the the animal, and then to some extent environmental. It is very challenging. I think everyone understands the One Health concept and the need for it, but then it comes back to funding. But that said, there are examples of successes. So there's the I think what's called like the tricycle initiative to test for or surveil for antibiotics in the human sector, animal sector, and environmental sector. But I think a lot of work still needs to be done. I don't have the answers in terms of how that becomes embedded, but potentially maybe one way we can think about it is a lot of times One Health is seen as a separate project. And maybe we can start thinking about as any investments that we do, One Health has to be a foundational component. But it is challenging. There isn't any easy answers, but it's a great question. Thank you.
Thank you, Wes. And Tim, yes, please.
Very quickly, I mean, ICARS, what the mission statement of ICARS is actually to address AMR across One Health sectors. So we have projects in human health, animal, and also environmental, because they're all, as Wes says, all sort of interlinked. In terms of, what can you do in terms of traction? The thing about ICARS is it's not just a bottom up, it's called looking at local needs, but we also work with governments. And so what we try and do is the implementation and the interventions that we do, try and produce data that will then lead to tractable policy in each of these countries, and hopefully also, by the way, be regional as well. So although it is difficult and it is going to get worse because climate change will drive AMR, particularly across the One Health sector with increased flooding and tornadoes and so on and so forth, let alone the insect population and wildlife, etc. But I think it can be done, but I think it has to be done in very focused, kind of research orientated sort of packages, if you like. But I think this kind of has to lead to a change in policy at a local level.
Thank you so much, Tim. Ghada, yes, please.
Thank you. I think the One Health aspect has been addressed by the previous colleague, but when there was a question about production, and I want to just highlight that we do have a tendency to lump all low-middle income country in one bucket, but the reality is the world comes with different capability, and there are many countries that are labeled as middle income country and upper middle income country, and there is a lot of assets there that could be developed. And we, for example, are turning to a country in Southeast Asia for local manufacturing when it comes to diagnostic and tests that are really relevant for the local need, because they take into consideration the temperature, the stability, etc., to a diagnostic tool, for example. So I just want us to be nuanced when we are lumping the majority of the world in that bucket of low middle income country, that there are capabilities and capacities that already exist in country. The question is prioritizing the need and seeing how country can work across border, especially within a regional perspective, because to be honest, many middle-income countries actually carry the burden of the rest of the world and manufacture and produce for the rest of us sitting in North America or Europe. So I just want that nuance to be taken into consideration. And when it comes to lack of data, which was kindly flagged, I think that there is data in many parts of the world. The quality could be questionable as much in certain high-income countries as it is in some LMIC countries. But I think we need to start thinking more creatively of data. Is there enough data to inform clinical practice? The work that we're doing in Zambia and Kenya is telling us that there is good enough data in certain clinical clinical settings, such as hospital, that could make and help the clinician have better informed decision about which antibiotic to use and for how long. And as such, we are working with entities like React Africa to shape up some softwares and some tools and digital asset to actually take some of this data and put it in the hand of the clinician. So we talk data for action in this case. So I don't think we are starting with nothing. I think we need to strengthen the data, and it needs to be really informing our action. Thank you, Afreenish.
Thank you so much, Ghada. And I think you have answered the query Lakmal has shared in the chat box, the utility of the data and importance of the data. Thank you so much. And with this, we have come to the end of our today's session. And I thank all my panelists for joining us today and your participation and engagement. It means a lot to us. And to all the participants, we hope you have found this discussion very informative and insightful. And we look forward to connecting with you again soon. Thank you all very much. Thank you so much.
Thank you. Bye-bye.
Bye-bye. Thank you.
Thank you, everyone.
Thank you very much.
Yeah,
Thank you very much, Afreenish, for
Thank you. Bye.
leading the discussion. Bye.